Room, we're going live.
Hello, Chris. Good
Hello.
morning.
Good morning.
Well, good morning, and we already have Mariana Savela and Vanessa Silva on stage to do our next session on how to avoid medical debt and helping consumers with coverage costs. So I am happy to take it away, and just want to say that you both are wonderful navigators, seasoned, experienced in our Covering Wisconsin Navigator affiliate network. So pleased to have you facilitating this session and speaking today. So thank you, and I will hand it over to you.
This morning, we are very happy to have Chris George presenting today about medical debt. She's going to focus in several aspects. 4 of those are to all of us to familiarize with insurance coverage and out-of-pocket cost. She's also going to focus on how to use other resources like prescriptions, coupons, discounts, and how to help that with medication costs. Also, she's going to talk about considering adding additional coverage like accident and critical illness besides the regular health insurance. And also, she's going to focus on charity care and payment plans. For today's agendas, we are also going to have 2 poll questions. And then after that, Vanessa and I will do a quick overview of how to avoid financial debt and also applying for financial assistance.
Thank you, Mariana. And we feel privileged to have Chris today with us, sharing about this important topic. I think all of us have experienced the situation where we have to advise our patients and consumers how to apply to different programs and different coverages. Christina George has been a dedicated professional in the field of healthcare since September 2013, when she first began working with the Affordable Care Act. Her passion for the ACA was immediate and unwavering, leading her to build a successful career in this vital area of healthcare. Starting as an independent agent, Christina's expertise and commitment quickly propelled her to co-owning a thriving agency in Wisconsin. Her agency is staffed by 18 dedicated professionals, specializes in Medicare, medical, and employee benefits. Christina's enthusiasm for teaching has been a cornerstone of her career. Over the past decade, she has leveraged her extensive knowledge to train agents nationwide, helping them understand the intricacies of the ACA and its positive impact on clients and families across the country. Her dedication to improving lives through healthcare education and services continues to inspire those around her. Thank you so much for being with us today, Chris. We feel privileged to have you here, and without further ado, the time is yours.
I am Chris George, the one with the pink hair. A lot of my clients, they may not remember my name, but they remember my hair color. So yes, medical debt is becoming a huge thing right now, and I want to help agents and consumers figure out how to get that down. So I'm going to give you some advice, some options to think about, and things to share. The objective for today is to familiarize yourself with health insurance, the coverage, what that looks like, and that out-of-pocket cost. I know sometimes are so focused on premiums, we forget about the out-of-pocket cost, even if they have insurance. How to use other resources like prescription coupons and discounts to help with medications, because that's a pretty big one. We're going to I want you to consider additional coverage, like she said, accident and critical illness besides just regular health. And lastly, we're going to talk about charity care and payment plans. So that'll be kind of at the end. So that my objective here is just to have you think about how to help your consumers and yourself to stay out of medical debt. So medical debt is still the number one reason for bankruptcy, and it's become a problem. There's affordable options. They protect their clients and your clients from debt, providing health coverage, encouraging them to visit the doctor when needed. Because that's one of the big issues, is that people won't even go to the doctor because they're afraid of it. So it's still the most common, even though people have health insurance. So the Affordable Care Act was created to help people get affordable insurance. That was the whole purpose, right? But medical bankruptcy is still happening. So despite that, over 90% of the United States population has some form of health insurance, whether it's through work or Badger Care or through the marketplace, medical debt is still a problem. People with limited assets, even a small unexpected medical expense, can just be unaffordable. The Nobel Prize winner was forced to sell his medal to pay medical bills. More than 250,000 people are trying to raise funds with GoFundMe campaigns. That's just unacceptable. According to the Consumer for Financial Protection Bureau, medical bills account for more than half of all the unpaid bills sent to collection agencies. More than half. Now, there have been some changes in how those can be reported, but if you don't pay your bill for 2 years, it will end up on your credit report. More than 1/4 of respondents said that they found someone in their household had a problem paying a medical bill. And of them, 11% said they declared bankruptcy in part because of medical bills. This is a problem. 20 million people, 1 in every 12 adult, owe medical debt. I've had clients walk into my office telling me they're paying off a debt from 10 years. One time, the longest one, 30 years. 30 years prior, they'd had this massive medical thing that happened in their life, and they were still paying it. Now, it was a minimal payment, but that's how long they had been paying for that debt. So how do they pay it? These statistics were actually pretty sad. They borrow money from their friends and family. They increase their credit card debt. Well, that's counterintuitive because now they're going to have interest on there that's even more expensive than if they had set up a payment plan. 41% take other jobs. 79% use up all of their savings, and 70% cut spending on their food, clothing, and household items. Now, yes, some of us could probably cut our budget for clothing, but to cut food, to cut household items that they need, this is not what we wanted when the Affordable Care Act was passed. So if they can't pay the medical debt, they're just skipping going to the doctor. So before the Affordable Care Act was passed, 32% of people would say they would skip doctor visits because they were afraid of the cost. So they didn't get medical debt, they just didn't go. It went down drastically as the Affordable Care Act was affordable. And then as rates and inflation and COVID, all that stuff started increasing, we had 28% in 2022 that just skipped going to the doctor altogether. That's not really working. So 28% of the US adults were forced to skip. They just delayed their care because they were afraid they couldn't afford it. The copay was too high. The coinsurance was too high. They just didn't go. In the past 12 months, 20% of respondents skipped their dental care due to cost. We just had somebody talking about dental. It's the most frequently missed form of healthcare, and your dental is important. Your gums are filled with lots of blood-rich nutrients are going through your gums. If your teeth are bad, your entire health is bad. So doctors, 16% of people skip doctor and specialist visits. 10% skip their medications. This is a very common thing. Medication's too expensive. They just skip it. 10% missing their follow-up care, and 10% just skipping out on mental health care. All because it was too expensive. So now that I've bummed you all out and you're like, oh, this is horrible, there are some solutions. But first, I want to make sure that everybody understands the difference between a deductible and max out of pocket. Consumers don't understand this. And if agents and navigators don't understand this thoroughly, not sure how we expect consumers to. So here's just a typical plan. Here is the deductible, $3,500. Here is the max out of pocket, $9,100. So the max out of pocket is the most they can spend in network for any kind of medical expenses. So if they reach $9,100 within that year time frame, the insurance will then pay 100%. But they have to reach $9,100 before that happens. Here's the copays for regular doctor visits, primary care. As you can see, preventative care is $0. And here is the coinsurance, 30% after deductible. So that 30% is what the consumer pays, not what the insurance. So the insurance in this situation would pay 70%. Here is a marketplace plan with the $0 deductible plan. These ones are great. They came out a few years ago. Molina was the first one in Wisconsin to show it. And for those who sell Medicare, I was like, ooh, an advantage plan for under 65. These are great. So here's the deductible, $0. Here's the max out of pocket, $9,100. Here's the copays, and there's the coinsurance. Wait a minute. It's not a coinsurance, it's a copay. Unusual, unheard of, and can save money. But there is a deductible, prescription deductible. So some people will get their EOB going, wait, I thought this said there was no deductible, and it says I've reached $0 towards my deductible, and they're all kind of panicking. It's the drug deductible that they're talking about. So if there's not a separate RX deductible, it's just the regular deductible. It's all combined. But if there's a drug deductible, as you can see, it's only for brand drugs and preferred drugs. Now, every carrier is going to be slightly different. I've seen durable medical equipment in that drug deductible. So you'll have to look at the summary of benefits to explain that, but that's where that deductible is coming from. The main difference between a copay and coinsurance is that copays are a fixed amount, and you will pay that amount until you've reached your max out of pocket. While the coinsurance is a percentage of the total medical cost, but you have to pay 100% of the bill until you reach the deductible. Both of these count towards the max out of pocket. It's not deductible and then another $9,100. The $3,500 is going into that max out of pocket. So I'm going to show you what that means. So with this particular bill or insurance company, a person goes to the ER. They end up with a $5,000 ER bill. Well, they have a $3,500 deductible. You pay that, and then you pay 30% of what is left, which is $1,500. 30% of $1,500 equals $450. So the total ER bill, $3,950. They have a horrible year. They end up in the ER again. They have another $5,000 bill, but you've already reached that max or your deductible. So you're only paying 30% of the bill, which is $1,500. So that ER bill is now $1,500. So they've paid towards that max out of pocket $5,490, with $3,650 left until they reach the max out of pocket. And just so you know, these slides will be shared so you can see them in the future. The doctor visit 2 weeks later equals a $40 copay. So even though they've reached their deductible, they're still paying the copay. So now they've paid $5,530 towards the max out of pocket. Now, this plan with the $0 deductible, let's assume same situation. ER visit. ER bill is $5,000, but there's no deductible or copay or coinsurance. It's only a copay. So they would pay that copay of $1,800 and the insurance would pay the rest. Your next visit, another $5,000 bill, but there's no deductible. There's the copay. So the bill is $1,800. So they have paid $3,600 towards their max out of pocket. And they have $5,500 left until they reach their max out of pocket. So there's it's much harder to reach that max out of pocket with this $0 deductible plan. So we're going to pull out poll question number 1. And I want you to think, I just showed you right there a way to help with medical debt. You can give the $0 deductible as an option.
Thank you, Chris. So we're going to go ahead and start with poll question number 1. And I see, yeah, people is already responding.
Excellent.
We'll give them 2 seconds more. I can see answers coming through. Okay, so the correct answer, well, people is still responding, but the correct answer is D, which is A and B. And most of people answered that one. And I guess there was a little bit of confusion, maybe. I see that's very tied to number B. Do you want to explain a little bit more, Chris?
And I can't see the polls, so I can't see what order they're in. So
okay, so 38% of people responded only the maximum out of pocket, and 45 responded the correct answer, which is the deductible and the maximum out of pocket.
And what was I can't remember exactly how I worded the question.
The question is, when someone pays a copay, does this apply towards and then the choices of the deductible?
So the copay, which is $40, $60, $1,800, applies only towards the max out of pocket. It doesn't apply towards the deductible because the deductible is only when you see it say 0%. In fact, I'll put this back here. The brand drug where it says 50% after deductible. So you have to pay 100% of the bill, whatever that is, whether it's a doctor visit, a prescription, to reach the deductible. But copays continue forever until you reach your max out of pocket. So they are not applying towards the deductible. All right. So that is one of the ways to prevent people from medical debt is the copay plans. To understand that a $0 deductible is going to save them money. Now, if they have a horrible year and they end up in the ER 8 times, yes, they're going to reach that max out of pocket. But being able to spend one night in the hospital and have a copay of even $3,000 versus a traditional plan that has a deductible where one night in the hospital, you're going to pay the whole $9,100, right? Those bills are over $20,000, $30,000. You're going to save them money by putting them in a $0 deductible plan. And Wisconsin's got great $0 deductible plans. We have lots of insurance carriers that have them. Every one of them is different. So you do need to read the summary of benefits before you start saying, hey, United's the same as Common Ground, that's the same as Quartz. They're all slightly different. They all have their pros and cons. But the $0 deductible is set up to help people. But the number one prevention, ironically, in medical debt is your annual checkup. That is the first thing. And people don't realize that it's free. So make sure when you're talking to your clients and prospects, you tell them it's free. Now, we do have to tell people you cannot show up at your doctor for your annual and start talking about your foot. You can't show up for your annual and start talking about your mental health. This is one of the things in our system that I think is broken and hopefully will be fixed, but it can only be the prevented things that are listed as free and preventative. If your doctor says, oh, I want to take additional blood work, I want to check your thyroid, the consumer needs to say, is that free and included in my annual? Now, it's not. And the doctor can say, well, you might have to pay a little extra. Then the consumer has been educated and informed that they might have to pay more for that extra blood lab. But as soon as they start talking about their foot, it now is no longer an annual visit. It's now become a doctor visit, and the labs are going to not be free. So this is part of educating your consumer. They need to get their annual checkup. Just do it. It will help them because if they don't go, how are they going to catch that, right? So here's the benefits. It assesses the risk for future health issues. It develops a baseline for your health conditions. So if you show up healthy and then suddenly you're not, something's weird, your blood pressure's going up, they can see it ahead of time. It helps you maintain a healthy lifestyle. A professional guide. You get to build that rapport with the doctor before it's an emergency. Because if you don't do that, you suddenly show up, you're having a heart attack, stroke. You don't know any of these doctors with any kind of rapport. So getting your annual help you find the doctor that you like, the one that you feel comfortable with. And you get better treatment options than trying to talk to your friends and families and Google. I have a teenager who loves to Google symptoms. And then she'll text me, well, I think I'm either dying or I have a cold. Like, you can't get your treatment, best ways of treatment from Google. And it's also your time to get the review of medications. If you need to have that more, we can get the review for medications so that your doctor can see what's happening. So why go? The goal with the annual wellness exam is to be proactive with your health. Doctors can often identify troublesome moles as precancerous. So you don't have to wait till the moles become cancerous. They can see it ahead of time and have it removed. They'll note when your blood pressure is going up, like, wait a minute, every year it's a little bit more. They can notice things before and help prevent heart attacks and strokes. So number one thing is definitely how to keep you healthy, preventative, and they're free. So make sure your consumers know this. The ACA's preventative mandate requires the plans cover evidence-based preventative services. They have no deductibles and copay and coinsurance for those preventative services, but they do need to stay in network. So there's a long list of what can be covered under those preventative. All right, cost of prescriptions. This is a big one. People will stop taking their medication. Here's a way to reduce prescription costs. Number one, encourage your clients to ask if there's medication options or alternatives. They can ask their doctor that, especially when they show up at the pharmacy and they're like, hey, it's a $1,000 prescription. They should be calling their doctor going, is there a different option? Often doctors do not know what it costs. They have a pamphlet, they had a brochure from the pharmaceutical company. They were told this is the latest and greatest thing. So make sure they know it's okay to ask. Have the client ask the pharmacist if there's a generic treatment option available and if it's appropriate for them. The second most important relationship somebody with medications can build besides their doctor is the pharmacist. Pharmacists, that's all they do. They work on day in, day out pharmaceutical stuff. My grandmother was saved from death by the pharmacist. Her doctor prescribed a bunch of medications and the pharmacist looked and went, I can't give you this. These two will kill you. You cannot have these two medications at the same time. That's their job. The doctor, it's not really the doctor's job. I mean, it kind of is, but they have so much more than just medications. So please talk to your pharmacist. And so many pharmacists are afraid. People like start yelling at the pharmacist. Well, my doctor prescribed this. How dare you question that? But they can give alternative options. And often they can tell you there's a generic version for that $10,000 medication. Compare different local pharmacies. Sometimes Walgreens is the most expensive. Sometimes the local mom and pop shop's less expensive because they'll go with whatever's least expensive. Sometimes it's Walmart. Sometimes it's Myers. They can shop around. Prescription, manufacturer prescription coupons. So I just pulled up a random expensive medication. I have no idea how to say this one, but here's the cost. If you looked at Single Care or GoodRx, it's over $5,000. This is an expensive medication. But at their website, this is the manufacturer's website, they have support, affordability, and $0 copays with private insurance. Well, guess what? The marketplace is private insurance. So this does not usually apply for Medicare and Medicaid. But if they're on the marketplace, that's private insurance. So they can go right to the pharmaceutical company and get it. And then alternative pharmacies and coupons. So here's a list of some very good places to look for coupons. Wellx.com, GoodRx.com, Community Cares RX, Farm Store, drugstoreunlimited.com, totalcaremart.com. Those last three are legit pharmaceutical stores here in the United States that are able to give the prescriptions to people here. Now it's going to be a mail order, but it's less expensive. Their doctor, and you can't just write yourself a prescription and send it in. It still has to come from the doctor. It still has to be approved. But these are ways to reduce prescription costs, because that's a big one that people just stop paying. Or they just look at a prescription that's $1,000 or $5,000 and they say, I'm not taking it. So here are some other options to protect your clients. Accident coverage. Sounds just like what it is. It covers accidents. If it's not a sickness, it's an accident. It even covers snake bites. So somebody gets bit by a brown recluse spider here in the, Wisconsin. That's an accident. You didn't, purposely take that spider and hurt yourself. It will cover copays and emergency visits and medication for accident. I had a lady break her ankle, slipped off the curb in the wintertime, broke her leg and her ankle. The accident coverage paid for everything. The ER visit, she had to take follow-up visits, cutting the cast off, all of that was paid by the accident coverage. There's critical illness policies. Critical illness will help with heart attack, stroke, organ transplant, end-stage renal failure. So there's different types of critical illnesses. Those typically are a lump sum. They give you $10,000, $20,000 to do with what you want when you are diagnosed with a critical illness. Cancer policies are cancer only. So they're less expensive because they're not covering all of them. They're covering just cancer. Prescription plans. There are plans that cover prescriptions. They're usually pretty inexpensive and can often be layered with a high deductible plan or a ministry plan. Dental and vision and hospital riders. These are things you can add. They all have different costs, but they will help protect your client. So here's some average costs. Critical illness and cancer policies will vary by age. The older you are, the more expensive it's going to be. But those policies typically are locked in at an age. Not always, but typically are. So if you can get somebody who's 30 to buy a cancer policy, they can keep that policy at the rate at the age of 30 up until they're 65, and sometimes beyond that, depending on the carrier. Common ground, silver and bronze, side-by-side plans. So here's a couple, age 50 and 52, income listed at 60,000, and I picked a random zip code from Milwaukee. So here's the silver plan with the deductible, and here's the bronze plan with the $0 deductible. Monthly cost, $510.80 versus $344.04. They're saving $166 per month for a total yearly savings of $2,001 by just choosing the bronze plan over the silver. Now, there are exceptions to the rules, but the specialty care copay on the bronze is $100 versus a silver $60 copay. But if they only go to the doctor, the specialist doctor, twice a year, they have saved money by being in the bronze plan. If they go to a specialist 4 or 5 times a month, then they might save money with that silver plan. So mixed insurance coverage, this is what it looks like. So there's that couple that had the bronze and silver. There's the plan. We layer an accident policy for a couple, a $10,000 critical illness policy, dental insurance, and their monthly premium is $507.72. This is reducing their out-of-pocket expense, plus we're adding the dental, and it's less than the $510 silver plan with better coverage. We're protecting them for that accident. We're protecting them for that cancer policy or that cancer diagnosis. And they're getting dental. So Anthem, silver versus United Healthcare bronze copay. Same couple, or different couple, less expensive or less income, 30,000. So they're in that CSR. So there's the marketplace CSR. So it's $1.79 versus free. So I do understand people, especially if they're doing it themselves, are like, oh, I can't afford anything. They want 0. You need to show them that silver CSR. Well, for $1.79, your max out of pocket is now $2,400 versus $9,450. So what does this couple look like? There it is, $1.47. I did a smaller accident policy. They don't need a big one. They don't need a $5,000, $10,000 accident policy because their max out of pocket is smaller. So it's only $15.75 for the both of them. A $2,500 hospital riders, which if they end up in the hospital is going to pay pretty much most of their out of pocket. There's the dental for two of them. Vision. Their premium is $95.80. It's a pretty good policy right there. Don't assume that because they're in that silver CSR that you shouldn't offer layers. I think sometimes we're like, woo, I would love it if my max out of pocket was only $2,000. But if somebody's living, really, truly living off of that just above Medicaid income, $2,000 is a lot of money. And they're going to have to set up a payment plan and be in it. Offer these options. Let them decide whether it's affordable. It's reducing their medical expenses. So we can work together to help Wisconsin consumers be protected and avoid medical debt. I want you to, if you're a navigator, find an agent in your area. If you're an agent, find the navigators. I remember when we had the navigators in Sheboygan County at the library. We went and met with them and talked with them, and we can really work together. So poll number 2, and then I will have questions. I can't see them, but we'll get to those.
Okay, so poll question number 2 reads like this. What are the best ways to avoid medical debt? A, get your year. B, utilize other insurance plans like accident coverage, critical illness protection, and short-term disability to help pay medical costs. C, create a GoFundMe account. D, options A and B. E, options B and C. So we see that people are answering the question and wait a little bit.
Yeah, get a little time.
Thank you so much, Chris, for sharing this important information. I mean, we're so used to deal with just health insurance coverage, but we, at least in a personal level, and I have never thought about, additional coverages, only employee benefits, but not offering that to people outside employee benefits. So, and I know you're going to.
If you're working with a consumer who has employee benefits, encourage them to take it. Quick Trip has got amazing employee benefits for part-timers. And I'm like, absolutely, take that life insurance, take that accident coverage. So that's why those layers are important.
Exactly. So we're going to end, and the results are there. Correct answer is D,
right?
Options A and B. So I see that most of our attendees answered option D. So that's great.
And actually, I found the button to find the Q&A. So it says, can I explain how the cost of medications works when the medication is a tier 1, 2, or 3? So if the medication, whether it's a tier 1 or a tier 5, if it has a copay, that's all you're paying for that medication. Now, the copay may be $10, but the prescription is $4. So I tell people the most you're going to pay for your prescription is that copay. So if it says it's $10, but it's only a $4 copay or prescription, you're only paying $4. So you're not paying $10. The insurance is just not kicking in until it costs more than $10. Or the tier 2, if it's $60, if they're saying you're responsible for the first $60 or that copay until it costs more than that. All of those copays apply towards the max out of pocket, not the deductible. The deductible is only applying when you're paying 100% for something and then has a co-insurance after it. There are some plans that you pay 100% towards the deductible and then you have a copay after deductible, but you'll see it in the summary of benefits when it says after deductible. So that means whatever that line item is, they're paying 100% towards the deductible, and then they're paying a coinsurance or copay after deductible. But every time they spend a dime, that is going towards the max out of pocket. Can someone use the prescription coupons even if they don't have coverage? Yes, though sometimes it will depend on the coupon. So almost all of those manufacturing coupons will say if you have private insurance or don't have insurance. What they don't want you to have is government insurance, which is Medicaid and Medicare. Unfortunately, Part D is part of that section. Now, there are some more coming. I have seen a few manufacturer coupons that will include the Part D or people who are on Medicare. And with all the new changes coming in Medicare, some of those coupons won't be needed because the max out of pocket is less. But that's what they mean when they say private insurance. They're not talking about Medicaid and Medicare. They want you to either have insurance or not have insurance. So then there's usually things like that, which we'll talk about a little bit later. Somebody said that, we've heard cautions about purchasing separate plans. I'm not sure why you would be cautious. Now, short-term can be done incorrectly. Accident can be done incorrectly if somebody is assuming that accident coverage is covering everything. Well, if you have no insurance, the accidents is only going to cover up to $2,000. Well, your ER bill's $5,000. Those layering options are supposed to be layered with insurance. They are not standalone insurance. You should not be offering an accident policy all by itself. It's in conjunction with health insurance to help reduce that max out of pocket. $9,100 is a lot of money. I don't know about you, but I don't have that laying down. Are critical illnesses and cancer policies medically underwritten? Depends on the carrier. Usually it is, it's less expensive. There are carriers that have guaranteed issue, but they're not going to cover pre-existing. But if somebody had cancer 3 years ago, they can buy a guaranteed issue critical illness policy now, and they can keep it for 5-6 years. And if they end up with cancer again, then it would cover them. Usually the look back for those guaranteed issues is anywhere from 2 to 5 years. So they usually are underwritten, but there's usually time. There are plans that you can get that are guaranteed issue. Sue says, what about copay assistance from manufacturers not being applied to the pharmacy deductible or out of pocket? Double dipping. Patients will go through financial assistance and not meet the pharmacies out of pocket. Will there be changes in the law on this? That I don't know. I don't know how they can keep track of some of this. If Johnson Sue's benefit wants to give somebody $1,000 towards medication, they can. Now, many carriers have stopped letting that manufacturer copay or coinsurance and copay deductions and stuff for those pharmaceuticals not be applied towards the max out of pocket. So in the past, you could take your pharmaceutical coupon, you could walk into Walgreens, you run your insurance, and the insurance is like, all right, this is a $5,000 bill. They run it to the insurance, and then you pay your coupon, which is you're going to pay $5 for it. But as far as the insurance is concerned, you've paid $5,000. Most are not allowing that anymore. If you have to pay $5 for that with that manufacturer coupon, only $5 of that prescription is being applied towards the max out of pocket. So they're not, the insurance companies then end up on the hook for thousands and thousands and thousands of dollars while the consumer didn't really pay anything. So it's not necessarily against the law, but those are changing. And I've seen many carriers that have taken that out. So the coupon does not apply. If you use a coupon, it will not apply towards your max out of pocket. That's also if you use a prescription, like a prescription plan, or you pay out of pocket, that is not applying towards your max out of pocket. That's separate. So if I go to totalcaremart.com and I buy my EpiPen there because it's only $100 versus $1,000 on my regular insurance, your $100 will not apply towards the max out of pocket. But if I'm super healthy and I never go to the doctor outside of my annual, I'd rather pay $100 for my EpiPen than pay $1,000 to have it applied towards a max out of pocket that I'm probably not going to reach. Skylar, have you looked into these cases in areas like far northern Wisconsin where there aren't many plan options? What about people who don't have other options? Any suggestions? I have some other areas people travel more than 30 minutes for one pharmacy, and that is an option. Yes, mail order. They really shouldn't be going to the pharmacy if they have to travel that far. Every carrier offers mail order. Typically, it's 3 months of prescriptions at the price of 2. But those other ones that I was showing on that slide, those ones also do mail order, and they can be less expensive. Same with the doctors and these plans. It will help if they, I know up in the north, I'm actually from Northwest Grantsburg area, just south of Superior. It's a long drive to find the doctor, right? And maybe the doctor who's next door is out of network because I don't want that small one. I wanted the bigger one. These accident riders, the critical illness things, those extra layers will help them in the emergency when they need to go to the closest one. And William, I can speak from experience that doctors often don't know the answer to that question, and they can't say what counts as the annual exam. So I know you're saying when I said, ask them if this is included. They do know. It's very clear. I know Prevea, my clinic, when I walked in for my annual, they hand me a piece of paper. And it says, this is what's included on your annual. They do know. And if the doctor's like, well, I don't know. Well, I can tell you, it's probably not included. Then you need to have him say, no, it is included. Well, I need that in writing. Tell your consumers to get things in writing. We deal with it all the time where somebody shows up. Why aren't they paying for my annual? I thought it was free. And there's like, yeah, there's 5 extra labs that were drawn. Did you agree to that? Did they tell you that that was not covered? Oh yeah, they kind of said something, or no, they just said what I like this. So, they need to, patients need to be their own advocate. Doctors are understaffed and overworked, just like 90% of the workforce. So I'm not blaming doctors on this, but they do know. The billing department 100% knows. They can get that information, but consumers should not agree to extra things unless they have been told, and it's in writing, this is covered by the annual. I know we've got like 17 minutes left. I did want to tell, if anybody's interested, I do host free weekly training webinars every Thursday at 10 a.m. This is central for anyone working on the ACA. Anybody's welcome to join. I've had presenters from insurance companies talking about their guaranteed issue. I talk about a lot of the consent and all of the things that are happening with CMS, what the income looks like. How do you count that? So everything, anybody is welcome. If you want to email me independently to get an invite, my email is there. If you want to see previous sessions, that's my YouTube channel. It's free for anybody because I firmly believe educated agents makes educated consumers, and then we're all healthier and we'll all be better off. I'm going to stop sharing. And then I know Vanessa, you've got something. And then if we need some more, we can do some extra questions.
Thank you, Chris. I don't know if you can talk a little bit more about the additional screenings part of the physical exam, because we know there are some additional screening tests that are covered under preventative. Can you talk about that?
Sure.
Please?
There is, so the immunizations is part of that. In fact, shingles is covered when you're under 65, but not when you're Medicare. So shingles is a good one to get before you turn 65. Alcohol misuse screenings and prevention, tobacco screening, depression screening, and domestic violence and interpersonal violence screening and counseling for women. So those are included. There is and if you go to healthcare.gov and look up preventative, it'll show you all of those, but those are some of the additional ones as well.
What about the mammograms when they were preventive?
Yes, so mammograms, colonoscopies are prevented. Mammograms, your first one is covered, and pretty much I think all the carriers will cover the 3D mammogram. If they find something, that first mammogram is still free. It's the second one when they're like, all right, we need to do some more testing, that will then be covered as a diagnostic visit. With colonoscopies, the first one is free unless they find a polyp. Then it could turn into a diagnostic visit. And we've had too many clients that suddenly got a $3,000 bill that they were expecting to be free. Some carriers are better than others at covering this. I can think of a couple of the nonprofits that said, well, if it's your first time going and this is not a history, we're going to cover it anyways, no matter how it's built. But again, that's something to talk with your consumer. I usually want them to be prepared. That's the one preventative that sometimes is not free and is a significant bill, right? $3,000 is a lot. So that $0 deductible plan with whichever carrier will talk about outpatient. So if they end up having a colonoscopy that needs some more work, it ends up getting billed as outpatient. So it's not $3,000. Usually those, I've seen them as low as $400. So that's another way to just prepare your consumer for that colonoscopy that might not be preventative.
Perfect.
Thank you, Chris. And another question would be, what would be an advice for either consumers or navigators about the explanation of benefits? We know that that can be very overwhelming. Sometimes when you enroll into a plan, or as a navigator, you enroll a person into a plan, and you have 4, 5, 6 pages, or even more sometimes, depending on the plan, depending on the carrier, advice for people to look at specific items in that EOB.
This year we'll have less plans to dig through than ever because the carriers are limited to, in each metal tier, to 3. So it's going to make it a little bit easier. As soon as those plans come out, as soon as I can get onto healthcare.gov or Health Sherpa, I am looking at those summary of benefits. I do on my YouTube channel, I actually do a deep dive into the summary of benefits as well as explanation of benefits, because I know those are 2 documents that are often confused. They show up, the consumer just goes, and they throw it in the trash. So again, as consumers need help, agents and navigators, go ahead and look at them. Go on my YouTube channel, find it, explanation of benefits, summary of benefits, and I will walk you through, because there are some very important things. 90% of them are, you look at 5 right next to each other, they're going to be the same. So once you understand how to read it really well, it won't be confusing, because they're really not that different. They all have the same information, whether it's a copay, a coinsurance, what applies towards deductible. They all have the same information. It's just the little nuances of, well, this particular procedure applies towards the deductible and this one doesn't. So don't be afraid of looking at that, because if you don't understand it, they don't understand it. Oh, and Alana said the shingles shot is covered with Part D now. So, all right, there you go. I work with ACA.
Thank you, Chris. And I'm seeing another question here. Chris, I don't know if you're able to see this one. Is from Sue S.
Sure.
Yeah. Do you want me to read that question?
Yeah, go ahead.
Okay. What about copay assistance from MFG not being applied to pharmacy deductible or pharmacy OOP costs? The double dipping. Patients will go through financial assistance and not meet the pharmacy OPM. Will there be changes to the law on this?
I don't know. That's one I have not seen. Right now, the law has all been about Medicare. It's all been about the Medicare changes. Now, 2025 is going to be the year of ACA, because the extension, the federal income poverty level chart, where before, if you were above 400%, you got no tax credit. And if you're below it, you did. That is coming up and expiring at the end of 25. The additional tax credits being applied so that it's 8.5% of your income instead of 10. That is running out. So I want, if you have access to your congressmen and stuff, Congress ladies, we need to let them know. I mean, this is an issue. Why is Medicare the only one who's getting a relief? You know, $9,100 is a lot of money for a family of 4, because 2 people, I mean, they can end up paying over $18,000 if something bad happens. So I don't know of any laws that are changing on that right now. It's up to the carrier. The carriers are one who are applying that. So that's why finding those alternative places, finding there are companies that will help pay for prescriptions. You got to find those so that you can hand those off to your consumer.
There is another question, Chris. How do you ensure consumer protection during an appointment, handle referrals, and provide information about additional coverages? Is there a list of additional insurance coverage options available in Wisconsin?
So how I ensure my consumer protection is 90% of my clients are in person, or I'm doing it by a secure link, and I record all my calls and my Zooms. Most of my people walk into my office. So same as many navigators, we have everything in our CRM that's protected. We've got all the paperwork for consent and the attestation. So we're following all of that. The biggest issue for that second part where you're like talking about information for additional coverages. Now you can run quotes without any, I mean, you're just putting in maybe a first name, a zip code, and a date of birth. There is not an exhaustive list because it's every carrier has something. United Healthcare, Allstate, Philadelphia American Life, Manhattan Life. I mean, Secure Life, like there's so many carriers and they're so similar. So I know navigators, you're not really contracting and working with these different carriers. That's why I want you to build a relationship with an agent that you trust, that you're like, wow, this agent's about education. This agent is going to help consumers. So you can say, I've enrolled Sue and her husband Bob in this plan, but they're interested in some accident coverage. Can you help them? You know, because the list is there's there's probably 100 carriers that cover Wisconsin with those accident and critical illness policies.
Thank you so much, Chris.
You're welcome.
Okay, I think we went through most of the questions. We will review some of the questions that if you feel like you didn't get an answer, we will review this and we will get back to you. We have a list of all the attendees. And the next portion of the presentation is going to be very brief. We only have 9 minutes now. And thank you so much again, Chris. Very important information, lots of details, and a lot of learning, even for us who may be experienced navigators 3, 4 years, 5 years. I mean, this is new information. Thank you so much. Okay, so we are going to, Vanessa and I are going to present very briefly about financial assistance. Just going to.
Oops.
We lost Mariana. Don't worry, I will
the
show
whole
my
session
screen.
without.
I will try to share my screen here. Okay. I hope you can hear me well. Okay. I hope I'm coming through.
Yes, you are
Mariana,
coming
go
through.
ahead. Perfect. Mariana, go ahead. I think I'm sharing or.
Okay. Yes, my apologies
Perfect.
about that. I disconnected. Okay. I'm just going to be sharing my screen here. Please let me know, everyone, if you can see. Okay. So I believe everyone should be able to see the screen now.
Not yet. I'm not seeing the screen. I'm not sure if others are.
I can see it here in the green room.
There we go.
Okay. Thank you so much. Like I was saying, Vanessa and I are certified health navigators. We have been doing this work myself for 3 years, and Vanessa has been doing this for 7 years. And we're going to be talking about medical financial assistance.
So the first slide, we know that each medical facility has its own financial assistance program, but in general, they follow the same rules, which is basically based in 3 items: income, family size, and financial documents. So it is very important to explain to our patients, consumers, that by family size, these medical facilities mean just close relatives, not extended family, no 19-year-olds and older or elderly parents living with you in the same household, is just the family. So any person that is older than 19 years old need to complete their own financial assistance application. And of course, the income and the family size is verified with the financial documents. Next slide. So by income documents, I mean that most of the medical facilities look at the 1040 federal income tax return, the most recent, and the most recent W-2s, the last 30 days of pay stubs. And when there are no taxes, no pay stubs, because we have immigrant consumers that get paid in cash, they can submit the employer verification of earnings that the consortium uses to verify income. And of course, the self employment report for those self employed when there are no Schedule C on their taxes, they don't file taxes, and no 1099s forms. So the self employment report is used, the same one that the consortium uses for some medical facilities. And of course, some items that the financial assistance reviewers look at is wages and salaries, annuities, pensions, IRA distributions, I should say, capital gains sometimes, investments, but not always. So we will go to the next slide, and I will ask Mariana to take over.
Thank you, Vanessa. And other items that we have to look at when we are applying for financial assistance is comparing what we have versus assets versus what is a financial need. Many hospitals, and depending on the hospital, depending on what's in the network, depending on what the specific rules they have, because we have seen that different hospitals, they have different type of financial assistance application, and we know that many of them, they have to follow these rules in general, but some of them can be a little bit more complicated, or even they can be a little bit more overwhelming on the process what they are asking for, depending on factors like assets like savings or checkings accounts, capital gains, investments, other financial needs like medical, monthly expenses, homelessness, unemployment, or Medicaid eligibility. Another factor also that is considered for some hospitals regarding financial assistance is the age of the person applying for this financial assistance, either employment or immigration status. As an example, we know that some families or some people that are coming here as a tourist, for example, if they go to the hospital for an emergency, depending on the hospital, but not many, and I haven't seen in 3 years of being a health navigator, I haven't seen a hospital that applies or gives financial assistance to someone who is here just as a visitor. Also, we have qualifying health issues, insurance information like the deductibles, the out-of-pockets and co-pays, and minimum medical debt. Depending again on the hospital, we have seen that if a person has health insurance and they want to apply for financial assistance, some hospitals, they will tell you, okay, in order for you to get a percentage, a discount, you need to have at least, I'm just going to throw a number, $25, 2,500 debt with us. Otherwise, you don't qualify for financial assistance. And then other considerations that we need to look at is always just make sure that you set up a payment with that medical facility, because that is going to help showing that you are really interested in paying your debt. And also be always aware that it's very important to respond within 30 days. Vanessa, you want to go ahead?
Thank you, Mariana. Always ask for a payment extension if you're experiencing financial hardship. And if your debt is sent to collections, it can affect your credit, as Chris mentioned earlier. Just don't forget, don't ignore your medical debts. It's what we advise to our consumers, and apply for financial assistance if needed. Okay, so we would like to thank Chris for her participation with us today. It was mind-blowing. I mean, I think we got a lot of good advices to share with our consumers, patients, and we thank you for your experience and knowledge, Chris. It was amazing. Thank you so much for being part of this session as a main speaker.
Well, thank you. I was honored. I was really excited to find out about this. Like I said, education is what I want. There is two people that asked the same thing for you guys. Are the medical facilities required to have some kind of financial assistance in Wisconsin?
The answer is yes, they are, because that is made with regulations for There are specific items that they are requested to ask people for, but it varies depending on the medical facility.
Yeah. And if they collect money from the government, then they have to. So there might be like not too many hospitals, but it might be a doctor's office who's some private cash only type of place, but they all have that ability. And Vanessa, Ruben says you're his beautiful wife and he's really proud of you.
Thank you. Thank you, Ruben.
Yeah. So thank you very much, Vanessa and Marianne. I enjoyed working with you two on this as well.
Thank you so much,
Thank you,
Chris.
Chris.
And we will bring Allison to the stage.
Absolutely.
Thank you so much. Yes, that was an excellent topic. Thank you for chatting. Important. I hope all the attendees came away with lots of new ideas and information about how to help consumers making choices and to avoid that medical debt, which is very problematic, as we know. So we have a 10-minute break, and then we'll switch to our final session today. So again, make sure you leave the session, come back into the platform to select the final session of the day. We'll see you in about 10 minutes. We'll start at 11 o'clock. All right, thanks, everybody.